will be presenting with Dr. Flynn. Oh, I skipped one. No, I didn't.
Okay, hi everybody. So this was a 9-year-old girl who we met a few years ago who presented with acute glomerulonephritis. And so initially she sort of read the textbook. She had a strep throat and then another infection, and she presented locally with seizures and severe hypertension. And her lab workup at the time at the outside hospital was consistent with acute glomerulonephritis. Everything looked pretty consistent with a post-streptococcal GN. She had normal electrolytes. She had a slightly high creatinine, slightly low albumin. Her protein creatinine ratio was quite high. She had all the right serologies, including elevated ASO titer, elevated anti-DNase B. She had a low C3, and she had a normal C4. And they didn't go any lower than 40 in the outside lab for C3, so can't tell you exactly what the number was. And then I met her like 3 weeks later at our, this was all in Montana, so at our Montana outreach clinic. She still was quite hypertensive. Now we're about around a month, I guess, after her initial presentation. So she had quite robust blood pressures. Even though she was on extended release nifedipine and metoprolol, she had edema, and she had had some weight gain. So I, thought, well, this is sort of an unusual post-infectious GN. We went up on our antihypertensives. We added Lasix. She had fluid overload and hypertension and was admitted locally, and then came here and had a kidney biopsy. And when she was here, we still had work to do on her blood pressure and her fluid management. But I think now we're going to show you the biopsy.
Yeah, so this is her biopsy performed in 2017. At low magnification, you can see that there is diffuse interstitial inflammation and interstitial edema. There's this very sort of pale quality to the staining of the interstitium. And even at this magnification, you can see there's something going on with the glomeruli. Looking more closely, all the glomeruli were diffusely involved by a similar process. They're hypercellular, they're very solid and lobular looking, and you get a sense of florid endocapillary hypercellularity within these glomeruli. You also begin to wonder if there's too many cells in Bowman's capsule in this one and this one. On the PAS stain, you can see that there is both mesangial hypercellularity and endocapillary hypercellularity. And indeed, on close inspection, and I'll show you in the next image as well, there were a few cellular crescents. I think crescents involved 25% of the glomeruli in total. So there was additionally glomerular basement membrane reduplication and remodeling. This was essentially a membranoproliferative looking process with a number of cellular crescents and necrotizing lesions. The immunofluorescence microscopy on this was really interesting. The only two things that stained positive by immunofluorescence were some IgG staining and some very bright C3 staining. The pattern was the same in them, so you can see that there's this kind of globular mesangial staining, and then there's this peripheral sort of confluent capillary loop staining. So C3 much brighter than IgG, nothing else stained. Electron microscopy was remarkable for a diffuse alteration of the glomerular basement membrane, where it was variably thickened, in some places markedly so, in others less so, by quite electron-dense material with extensive effacement of overlying foot processes. And you can see that electron-dense material continued along the basement membrane as it laid over the mesangium, as well as out in the capillary loops. It seems to mostly be intramembranous, occasionally subendothelial. Rare, it didn't often get subepi. Here's like a rare instance of that. And you can see that there were collections of similar looking material within the mesangium. So taken together with a C3 dominant immunofluorescence staining, with a membranoproliferative pattern, and with this appearance by electron microscopy, this was diagnosed as C3 nephropathy, and specifically dense deposit disease.
Great. And then, so we treated her with steroids initially. We sent the complement panel to the Iowa, to the Morrill lab. So she had a C3 nephritic factor, a C5 nephritic factor. She had an elevated C5b9. She was negative on factor B and factor H autoantibodies, and she was negative for a C4 nephritic factor, and their diagnosis was C3 glomerulopathy. They did not have the kidney biopsy results. She had one of the most malignant courses I have seen. She required another hospitalization for fluid overload and hypertension, and then she required kidney replacement therapy, starting with CRRT, then intermittent hemo, and then finally she was converted to home peritoneal dialysis because she had just no progressive loss of kidney function and no recovery. So she remained on chronic dialysis until she received a deceased donor transplant in November. Now, we had been doing complement studies periodically while on dialysis, and the ones most proximate to the transplant date showed a C3 still unmeasurably low, C4 normal, the AH50 below 10%, and then a positive C3 nephritic factor. So we knew that her complement activation was all still very active. And so at the time of transplant, she received eculizumab prior to the transplant. Following the transplant, she got plasma exchange following the transplant. She underwent our standard thymo induction. She got mycophenolate, tacrolimus, and prednisone for her baseline immunosuppression. And subsequently, she's been doing pretty well. She's got a pretty normal kidney function, a bland urinalysis. She's on a little bit of amlodipine. She's now on ravulizumab every 8 weeks yes, thank you for that question, Ram. She received eculizumab pre-transplant and it did not help. I failed to mention that. Thank you for asking the question. Now she's on ravulizumab. There's some evidence that, at least some case reports, you probably have to say, that ongoing treatment with eculizumab or ravulizumab may be helpful to maintain things post-transplant. As of January, I don't know how hard it is. We got it approved I'm not involved with that piece, fortunately. Anyway, her most recent serologies showed normal C3, although quite low, normal C4, again, AH50, less than 10%. Her C5b9 is normal, she still has 4+ C3 nephritic factor. And now we're going to show you a biopsy done 2 months post-transplant.
Yeah, so this was a surveillance biopsy, which we saw earlier this year. And I want to give a shout out to the whole crew at University of Washington Renal Pathology, particularly Doctors Smith, Alport, and Najafian for their assist on this case. At low magnification, this kidney is strikingly blue for a kidney that was only transplanted 2 months prior to this biopsy. And indeed, on higher magnification, you can see that there's extensive kind of diffuse interstitial fibrosis. The tubules are a bit small, but actually have decently preserved epithelium. But boy, there's a lot of blue in between those tubules. The glomeruli look pretty good, however. They look good at high magnification as well. Maybe a hint of hypercellularity here. But in general, the gloms looked fine. They look fine by Jones Silver as well. And they look fine by PAS. So the main action by light microscopy seems to be in the tubules and interstitium in this recently transplanted kidney. However, immunofluorescence microscopy, this was where we needed the help, because it's a little bit hard to tell whether this is typical non-specific C3 staining or whether in this patient with a history of dense deposit disease, this is significant. What we saw is some fairly bright C3 staining, and I apologize for the quality of this picture, it's the best we have, that involved glomeruli, including some mesangial C3 staining and some Bowman's capsule staining. And then we also saw C3 staining in tubular basement membranes. And so based on this, we were concerned that there might be recurrence of dense deposit disease, but we looked at the electron microscopy and there's nothing super specific for it. So this is, the stain quality on this image is kind of funny, but what I want to show you is that the great majority of the glomeruli have really normal appearing glomerular basement membranes. We did not see any convincing dense deposits. There are these occasional areas of sort of glomerular basement membrane folding and thickening, but we don't see any electron dense osmophilic material. This is probably the weirdest that it gets in terms of the quality of the glomerular basement membranes. And this is a close-up showing areas where perhaps there's a bit of thickening, there's a bit of folding, maybe it gets a little bit more electron dense, but I don't think there's any sort of convincing deposition here. And then there's some other areas where it's kind of more diffusely thickened, but not by electron dense material. So we were worried about this patient. And we were worried about the C3 staining and not sure what to do with that C3 staining, and not sure how to determine whether it was specific to a recurrence of her disease or just non-specific C3 staining. Oh yeah, we also saw a little bit of electron dense material out in Bowman's capsule. And so we showed it we showed it to Laura Flynn, and then we also showed it to the University of Washington folks. And putting our heads together, what we came up with is, it seems like perhaps that C3 deposition could be concerning for early recurrent dense deposit disease, but it's certainly not specific for it. So we're left with the sort of unsatisfying conclusion that maybe there's recurrence, maybe not. And the worrisome thing here is that in C3 nephropathy, the recurrence rate is 50 to 60%. And eculizumab has sort of a mixed bag in terms of its efficacy, seems to work in some patients. And when I looked in the literature, I didn't find a good description of what very early recurrence looks like in a graft. So I don't know if that's what we're seeing or not. And then the other thing I wanted to highlight in this biopsy was how extensive the interstitial fibrosis was, considering, again, this was only 2 months ago that the kidney was transplanted. And we know that it's not a pre-existing condition in this kidney because this is the kidney from our first case. This is the kidney from our second case. And these were from the same donor. So we know that the donor didn't look like this when the kidney went into this patient. So we wonder whether this could have been ischemic injury sustained at the time of transplant. But again, it's a little bit worrisome for the long-term function of this graft.
Right. So thank you, Robyn. That's great. I had forgotten that they had the same donor. So, I mean, she's getting, she just had ravulizumab on Monday or Tuesday of this week. And so we're waiting. she gets the full serologies every time she gets her ravulizumab, so we're waiting to see if there's any change. But boy, that her kidney function has been rock stable and not even a single red blood cell on her UAs. So far, so good. And this family was so miserable on dialysis, and they are so happy to be off dialysis. So.
My gosh. Well, I hope that continues.
So do we know what the C3 stain looked like in the biopsy from case 1?
Yeah, I've got the report here. Let me take a look.
That might help you clarify what the significance of the findings in case 2.
Oh, wait, did we do, hang on. I'm looking to see whether we did immunofluorescence on that. We did not do IF on the transplant biopsy for case 1. We only did EM.
Oh.
Wait, is that right? I'm looking, hang on. Yes,
Is there
that's
any
correct.
chance you still have frozen tissue?
You know, we might. We don't throw anything away.
I think that would be a really useful study.
Oh, yeah, that's a good point. Okay, so your position would be that if we were to perform IF on that transplant and we saw C3 staining in a similar pattern, we could say, hey, this is probably not really anything bad. This is just a condition of the kidney.
Well, it helps. I wouldn't say that, but it helps with your inference. But if you saw nothing, that's where you really get a lot of help.
Right.
Yeah.
I guess I would also add to that, it would help case 1 itself because of the considerations of circulating factors, including immunoglobulins or stimulation of complement in the setting of some other factor.
That's true. Yeah. All right. Yeah, I'll see if we still have tissue. That's a cool idea.
For case number 2, how sensitive is the finding of, let's say, if the patient did not have drusen on eye exam before and now has drusen? Would that mean that, you know, it's a dense deposit disease in the kidney early on, and we haven't caught like sausage-shaped deposits?
I mean, I think that's a good question. I don't think she had anything. I'd have to look to see whether she had an eye exam at the beginning. Daryl, you might know.
I don't think she did at the time of diagnosis.
Yeah, things were a little chaotic. I mean, as you can tell from the description of her clinical course, it was a bit, I'll use the word chaotic just because of how rapidly things went poorly for her.
Robyn asked the question of whether or not this is a kind of consistent or how we see dense deposit disease occur in adults. And I would suggest if there wasn't a vascular concern, we still would be watching for proteinuria that would come prior to even hematuria or a rising creatinine. And I'll just leave it at that, as you have good amount of experience with that too, Joseph.
Yeah.
Thank you. That's helpful.
Yeah, I think her last protein creatinine ratio was like 0.1 or something.
Yeah, especially in dense deposit disease, what looks like is in the literature that you see histologic recurrence even before you see any clinical recurrence. Studies have shown, you know, histologic recurrence as early as about 4 months, with, you know, average clinical recurrence at about a year, sometimes 2 years. So we're on the watch for it with surveillance biopsies.
Shall we do our last case? I'm going to present this one with Dr. Okamura.
Yeah, so this patient is I'm presenting the whole thing a little bit differently than the other two cases, but this is a 15-year-old young teen that I've been taking care of for a while. He was diagnosed with Alport syndrome fairly early in life, and he received a deceased donor kidney transplant this past January. Prior to transplant, he had significant hypertension. He was on multiple drugs, metoprolol, nifedipine, chlorthalidone right before transplant. Earlier in his course, he was both on ACE and ARBs. Interestingly, in his course towards the end, he was noted to have a more rapidly rising creatinine right before transplant. At that point, he was already listed for transplant and got his creatinine a year prior was 4.4, and then in September went to 6.2, and then from September to January had a rapid rising to 11.1. We were actually planning to put him on dialysis when he got the call for transplant. We thought at that time it was due to, he was in a period of active growth. He was increasing both in height and weight. He gained almost 10 kilos of more muscle mass over the past year, as well as increasing in height. He had a similar sort of scenario, about 7 years prior to that, and got a renal biopsy to see if he had some other diagnosis. So as I mentioned, he was diagnosed at about 22 months of age. He presented with gross hematuria, a creatinine of 0.4, and some proteinuria. His mom did have microscopic hematuria and proteinuria, so it was thought that he either had IgA or Alport. He underwent a skin biopsy, which showed normal staining for collagen 4, and then he had genetic testing a little later after that, which did show a mutation in exon 38, sequence change, very typical, in collagen 485, and he got as I mentioned, he had a renal biopsy because his creatinine had almost doubled in the absence of any kind of real significant growth or illness, and we were wondering if he had possible IgA in addition to his Alports, but Robyn will sort of discuss that biopsy. Next slide. So his birth issue is fairly unremarkable. He was on standard CKD drugs. His physical exam was fairly unremarkable. When his creatinine was rising, his blood pressures were actually under pretty good control. We were doing telemed at that time, so those are his range of his blood pressures. We did push up his metoprolol anyway, since his systolics were running a little higher. And those are his labs, as you can see, which is fairly unremarkable. Because of his transplant, he had his degree of proteinuria measured to know how much protein excretion he had and get a fairly good amount. So he did have a unilateral nephrectomy at the time of transplant.
So I'm going to show you his 2014 biopsy, which was performed, I think it was performed after he had received his molecular diagnosis of Alport disease. And then I will show you his nephrectomy that was done earlier this year. So as Daryl mentioned, his 2014 biopsy was an inadequate biopsy in the sense that we received only medulla for light microscopy. However, Flynn was able to salvage some of the tissue that was used for immunofluorescence and process it for electron microscopy. And so I'm going to show you a couple of toluidine blue images of these glomeruli, which were interpreted as looking pretty normal. I don't know, you could make a case for maybe a little bit of mesangial hypercellularity here, but also that could just be toluidine blue weirdness. Electron microscopy in this case showed uniformly thin glomerular basement membranes. So here's a set of measurements showing that these were indeed on average thin for the patient's age. There's well-preserved foot processes here, although there was some effacement in some of the sections. And in some areas, you can see variation in basement membrane thickness with a hint of kind of a lamellation of the lamina densa. And here's another area showing, again, variation in thickness with areas of marked thinning, alternating with areas of thickness and kind of irregularity and sort of a laminar appearance. Dr. Flynn also did collagen-4 immunofluorescence staining, which showed negative staining for collagen-4 alpha 3 and 4 alpha 5. And so that was supportive of Alport syndrome. And so this was signed out with sort of a cautious diagnosis because of the limited sample of abnormal collagen-4 staining pattern, laminated glomerular basement membranes, limited sample, but overall the findings confirm the diagnosis of X-linked Alport syndrome. So we then received just this year his nephrectomy prior to transplant, and you can see that it was a rather small kidney with a few small cortical cysts. And by light microscopy, there was extensive cortical fibrosis. This is an image of trichrome of the cortex, and you can see that there's just widespread interstitial fibrosis, widespread tubular atrophy. It looks like an end-stage kidney. Same appearance at low magnification on Jones-Silver stain. But as you go in more closely, you can see that the glomeruli in particular have a number of distinct alterations. Probably the majority of them were involved by segmental sclerosis, which is kind of the described end stage in Alport syndrome. So that wasn't a big shock. What was surprising is that every so often, if you hunted around, you could find a glom that looked like this, where you get a sense that there's perhaps a little bit of an early cellular crescent forming in Bowman space. And like this, where there's definitely a cellular crescent forming in Bowman space. And every so often, I even found a little focus of segmental necrosis. There's a little bit of fibrinoid necrosis in the center of this glomerulus. And you can see pretty clearly places where the glomerular basement membrane has been broken and there's an inflammatory response adjacent to it. And that was kind of a new one on me. I wasn't expecting to see necrotizing and crescentic lesions in an Alport syndrome kidney. The other striking thing was the progression of the electron microscopic findings compared to 2014. So remember in 2014, what we mostly saw was thin glomerular basement membranes. Every so often, if you hunted around, you could find areas where there was irregularity and lamellation. By contrast, in 2021, in the same kidney, there is diffuse effacement of foot processes with this extensive microvillus transformation. And you can see that now the basement membranes are very irregular in their thickness and composition. So looking more closely, you can see areas of dramatic thinning right next to areas of dramatic sort of widening and rarefaction. And you can, in some places, you can still see sort of a lamellation, but in some places it just looks kind of rarefied. And I was also struck by the fact that now even the tubular basement membranes have distinctive irregularities to them, kind of similar to what's going on in the glomerular basement membranes. And so this was I signed this out as an end-stage kidney, features consistent with Alport syndrome, including that glomerular basement membrane irregularity, the foot process effacement, and the segmental and global glomerulosclerosis. But then there's also this segmental necrosis and cellular crescent formation. And when I did some reading about that, I discovered that our very own Drs. Alpers and Flynn wrote a paper a couple of years ago characterizing this in a case report. So crescent formation has been described in multiple case reports in Alport, and it's also been described in a mouse model. It seems to be associated with X-linked Alport. In this case, it was an initial presentation, which is pretty wild. And it's not totally clear why you can sometimes get crescentic glomerulonephritis in an Alport syndrome kidney, but perhaps it has something to do with glomerular basement membranes being thinned and having reduced strength in these kidneys. And there's normally very high intracapillary blood pressure within glomeruli so that you can filter. So perhaps you're just getting a sort of a hydrostatic rupture, and that glomerular basement membrane break leads to crescent formation. So I thought that was a really cool case, and wonder if that was something that other folks had seen. It was a new one on me. And now I see that there's like a crazy conversation going on in the chat, so maybe we can talk about that. Let's see. Bazad asks, did we do IF or IHC on the nephrectomy? No, we did not. And oh, there seems to be electron dense deposits by EM in the nephrectomy. Oh, let's go back and look.
Yeah, Robyn, this is Bazad. Fantastic case. Yeah, there is a one there, and also a few here and there. So I was just wondering if there was a concomitant process going on.
Well, that's an interesting question. Gosh, I don't know, and I don't think we saved frozen tissue. I think when the pathologist who got this explant came to me and said, "What do you want to do with this?" I said, "Throw some in glutaraldehyde," but it didn't occur to me to freeze any.
We can do pronase digestion immunofluorescence here on the nephrectomy specimen if we want.
That would be
IgA would be a good suspect here too, right?
Yeah.
For the concurrence with thin basement membrane like disorders as
those
well.
tend to travel together.
Yeah, they have a higher coincidence. So at least in thin basement membrane disease, the most common concurrent glomerulopathy or glomerulonephritis is actually going to be an IgA nephropathy. And so, here these deposits are suspicious for, immune deposits. And I think, thinking about the crescents or crescent-like lesions you're seeing, that could be one potential explanation.
Oh, super interesting.
Yeah, that's a very good point. Also, I mean, rarely immune complex mediated process secondary to probably exposure of the epitopes, the glomerular basement membrane that are otherwise not exposed causes immune complex glomerulonephritis, similar to membranous or sometimes even with mesangial deposits similar to this case.
Interesting.
And somewhere in the old literature, there's a study from Colombia that actually tried to make the case that Alports might even be an immune complex deposition process because they early on found a series of patients that had some electron dense deposits like this. I don't remember the details, but I remember thinking that was an extraordinary conclusion and probably quite wrong.
Wow. That's fascinating.
The higher magnification picture of that one deposit looks more like cell debris, and so I think with all the injury going on, I wouldn't hold my breath. Yeah,
this looks like cell debris for sure. But that other one, I'm going to go back and try and make it bigger in the PowerPoint. Let's see if it'll behave for me.
And you can get crescentic glomerulonephritis with Alports and no other potential cause. So
yeah,
it's reasonable.
Well, maybe I'll try some immunoperoxidase immunoglobulin stainings since I've got the material for that. And certainly if we see any evidence of recurrence in the graft, that would sort of up the ante in terms of going back and characterizing what was happening in the native kidney. All right, well, it's right at 9:30. So I will thank all of you for your attention and for the terrific ideas and for the terrific conversation here. And thank you so much for inviting us.
Thank you so much, Dr. Reed, and all the presenters for the discussion today and everyone for the robust discussion in the chat. Hope everyone has a good weekend, and we'll see you all next week.
Thank you.
Thank you. Fantastic cases.